Hello, listeners. Welcome to Born Curious, coming to you from Harvard Radcliffe Institute. I'm Evelise Estrada.
And I'm Heather Min. On this podcast, we lead with curiosity, bringing you conversations that shine a light on the ideas and research happening here at Radcliffe.
Today, we're exploring a topic that touches millions of families, but is still often shrouded in stigma. We're talking about substance use disorders and how they affect women and girls in particular.
Our guest is Dr. Shelly F. Greenfield, a psychiatrist at Harvard Medical School and McLean Hospital, where she leads the Division of Women's Mental Health. Her research focuses on gender differences in addiction, how it develops, how it's treated, and what recovery can look like when care meets people where they are.
So let's get started. Welcome, Shelly.
Thank you so much for having me.
We recognize that you specialize in women and substance use disorders, but we'd like to start by learning about general issues around addiction.
So let's start with a little bit of context. How was addiction viewed versus how it's viewed today?
I am not a historian of science, but I think it's true that in the past, addiction was often viewed as a moral failing. This historical frame, it continues at times to reverberate in our society. But it's really important to know, that much progress has been made over many decades, certainly beginning as early as the 1970s and continuing to the present day. Science has shown that addiction is a complex biopsychosocial condition. We have a lot of neuroimaging data and other neuroscience research that demonstrates that there are changes in the brain in response to substances. And these are drivers of behaviors, such as compulsion to use substances, even in the face of a range of harms that a person might experience. We know, just to be more technical, we know that addiction it's a dysregulation, a pretty serious dysregulation of motivational circuits in the brain, and it increases the rewarding effects of drugs, and this underpins substance-seeking behaviors. So we also know, importantly, that this process can be disrupted by a range of effective treatments, and people can be treated and successfully recover.
So our conception of addict is outdated.
Yes. In fact, we don't really even use the term addict anymore. Research has shown that the word addict and other words like that are actually stigmatizing terms, and they actually make a difference in our society and health system. We use what we call person-centered language, such as a person with a substance use disorder. This is language that's been demonstrated to actually destigmatize a range of conditions, including substance use disorders, other psychiatric disorders, and frankly, other medical conditions. So we say a person with whatever the disorder is, because the disorder doesn't define the person. The person's the person, and they have a condition or a disorder. And in that way, it also helps us really drive home the point to patients, families, doctors, other clinicians, that these are treatable conditions that have to be diagnosed and then treated.
Can you say a little bit more about that?
Well, what we were talking about is that we're addressing stigma, but we have a long way to go. And one of the ways for us to think about this is that when we diagnose a substance use disorder, there are 11 different kinds of, symptoms and behaviors that we use. And what's so important about that is that, like any other medical condition, what we can do is diagnose something that's mild, moderate, or severe. That's so important because it's what we do with other medical conditions. So what we do is, if it's the beginning of heart disease, for example, we start treating their person's cholesterol. Let's say they have high cholesterol. We don't ever wait for somebody to have severe cardiovascular disease and have a major heart attack, to blow out their heart, essentially, to begin to treat heart disease. So why would we ever think of a substance use disorder in that way?
Okay, so how do you define a substance use disorder?
We have 11 symptoms across 5 domains. The first is loss of control over a substance. which I'll explain in a moment. The second is the way in which a substance might impair your functioning, your social function. A third is risky use of a substance. A fourth is tolerance. And a fifth is withdrawal from a substance. So I just want to explain what I mean when I say those things. When I talk about loss of control over a substance, that generally means somebody who has tried to cut back on their use, but just hasn't been able to do that. Or they could be somebody who finds themselves having a lot of cravings for a substance when they're not using it. It means that somehow you're not in control. Social impairment is the way that sometimes using a substance can impair your social relationships, and that can be your home environment, your way of interacting with your family or your friends. It could also be at work, and it can also be that you've all of a sudden decreased your investment or time in certain things that were previously quite meaningful to you, like, important social or recreational activities. The risky use we talk about is really when people are using a substance in a kind of physically dangerous way that might harm themselves or somebody else, or that they've begun to have some either psychological or physical problem as a consequence of their use. Tolerance is when somebody has the experience where it takes more substance to achieve a certain effect. So like they used to feel intoxicated by a small amount, and then all of a sudden they realize they need like more than that to have that experience of intoxication. And finally, for some people, for some substances, when they stop using or really decrease in a major way, they will find themselves having certain withdrawal symptoms. We have 11 symptoms across those domains, and what's important is that if you have 2 or more of them, we think of you as having a substance use disorder, a substance use problem. And what we can do is actually look at fewer symptoms as a mild problem, more becomes moderate, more than that, severe. And that is incredibly important, because if you have a mild use disorder, then, treatment would be geared to that. I think that what's so important and flies in the face of the way I think sometimes people have stereotypically thought of things, is that it's such a range. And people should be met where they are and get help at the moment in time for what is actually occurring in their life. And we never, for any medical condition, ever want to wait till something is so serious that it's a medical emergency. We're always hoping in everything that we do that we can intervene much sooner.
So it sounds like you're describing a progression, both in terms of substance use and treatment.
People think of people with a substance problem as somebody who's really gone all the way to a place that's very, very severe. We think of this as a continuum issue, and the diagnostic criteria help us do that. So we can say, this is mild, this is moderate, this is more severe. Here's what we're going to do. And then if that doesn't work and we need to move you to something that's a little more, we'll do that. And then we'll do that. And we can engage people around those conversations. And people can say to us things like, I don't really want to do that. Once upon a time, if you said that to somebody, they would say, well, that's too bad. Go hit bottom. That's like a crazy idea. So we say to people, that's fine. What about engaging in a group? Like we have a professionally led group here. Would that be okay? No, I hate groups. Okay, well, we have counselors. Would it be okay with you to start like one-to-one treatment, and we can see how you're doing? And, we also have medication. Would you be interested in medication?
So what is the current state of this problem? How many people are affected, and to what degree?
In answering that question, I'd like to use the latest data that we have for the United States, which is something called the National Survey on Drug Use and Health. It's done annually, and it is produced by the Substance Abuse and Mental Health Services Administration in the federal government. So these data came out in October, I believe, of 2024, and they reflect 2023. In the United States, 17% of the population 12 years and older had a past year history of having a substance use disorder. So that's 17% of the population. It includes 10% of the population who had an alcohol use disorder, 9% who had another drug use disorder, 5% with a cannabis use disorder. Those are not mutually exclusive because you could have an alcohol and a drug use disorder, but it gives you an idea of how significant the problem is. What's really important to know is this isn't substance use, like who's using substances. That's many more people using various substances, nicotine, cannabis, alcohol. These are the people who met for criteria for having an actual disorder.
I want to something that stuck out to me is that you said 12 years and older.
Yes.
So starting at 12 years old.
To hear 12 and older, it's alarming and jarring and surprising.
If you look at people who are 18 and older, you're looking at adults. And it's been very important for public health and clinical purposes to understand what's happening in the adolescent age group. The earlier you would know something's happening, the more likely you are to be able to intervene, the better it is for the individual and the potential longer-term outcome.
And you focus specifically on substance use disorders in women. So can you tell us more about that?
I do have a specific interest in what we think of as gender differences with a focus on women. And part of that is because women have traditionally been very underserved in terms of treatment and treatment development and access to care for all sorts of reasons that we can talk about. And I just gave you the data for the whole population, but for women, for example, 14% of women 12 and older had a substance use disorder. And for substance use disorders in the 12 to 17-year-olds, it has flipped, where females are more likely to have certain types of substance use disorders. So that is extremely concerning. I would just say, we were talking about use disorders, but another thing that we know is been an escalating problem for Americans, males and females, has been what we call binge drinking.
Can you define binge drinking for our listeners?
For males, it's considered 5 or more drinks on a given occasion, and for females, it's 4 or more drinks on a given occasion. What we're seeing is that 21% of everyone in the United States meets criteria for having a binge alcohol use in the past year. That includes 24% of males and 19% of females. So that's not a use disorder per se necessarily, but that's using alcohol in a way that could potentially be harmful for individuals' health. Women in general are more likely, prevalence-wise, to have, in the course of their lifetime, major depression or mood disorder, anxiety. They're about 3 times as likely to have a trauma-related disorder, and they're 3 to 5 times as likely to have some eating disorder. What you can see is that if these things disproportionately affect females, that may place them more at risk.
So while at Radcliffe, you're looking at rising rates of substance use and the related consequences in women and girls in the United States. So what are some things, 1, 2, 3 things that you want people to know about this issue?
Over the past 3 decades, we know there have been these rising rates of substance use in women and girls across the lifespan. It includes alcohol, cannabis, and other substances. What's happened is it's led to this narrowing of what we call the female-to-male gender gap in substance use disorders. It's about, across the whole population, it's about 1.45 to 1 now. That's down from in the 1980s. For alcohol, for example, it was 5 to 1. So you can see there's been this incredible narrowing over time. Also, by 2019, for the first time, girls, 12 to 17-year-old girls, exceeded boys in having past year substance use disorders. That never has happened. And that gap has increased so that 12 to 17-year-old girls, it's even about at 2 to 1. I mean, girls in that age group as of last year are twice as likely than a boy to have a past year substance use disorder. So this is really different and really changed.
Hearing that substance use disorder among adolescent girls has passed the level of disorder among boys is surprising. As a psychiatrist, Why do you think this has occurred?
Well, so that's a great question. So my project that I've been working on here at Radcliffe and continuing to work on is aimed at trying to understand what are some of what we call the drivers of women's current use of substances, and do these vary with age and stage of life, with different types of substances. So, we know there are many hypotheses, and we're trying to learn more about these. So, for example, which factors are most salient for women at different phases of life and across substances?
My mind immediately goes to social media.
So is it social media? Is it stress? Is it depression? Is it anxiety? Is it traumatic experiences? Pain? Insomnia? Is it stress from the pandemic and other things? And what we think is it's multifactorial. It may be many of these things for different ages and stages of life, or different substances even. We're trying to explicate more of that because we think it will help for people who are clinicians, but also actually will help think larger in terms of policy and what we need to do to assist, our whole population, actually.
Because you have to treat the cause, right? Not just the condition.
Yes. As part of the Radcliffe Project, we've gathered information from about almost 2,400 women 18 to 70 in the United States. And what we're really interested in asking them, the survey asked them about their substance use, alcohol, cannabis, other drugs, and about all these factors that we just discussed to understand what might be correlated with what. So if you're much more likely, for example, to have assault, physical or sexual, and have a trauma-related disorder subsequently, that poses a risk. So for everything in health and well-being, we think about what are our risks. So we think about, I had a family history of cardiac disease, and your doctor will say, well, that may pose a risk to you. So it's a similar kind of thing if you have had a family history of having a substance use disorder in your family. We don't know that you will have one, but we think, well, that could pose a risk. You could be more genetically predisposed. In addition, we know that there are a lot of other kinds of external factors that can, weigh in for people of all ages. And those are the things that surround them in their environment and in their social environment. That can be their peer group, the people that they're with, and their families. The other thing we sometimes think about are commercial determinants of health, which are industry and the ways in which industry will advertise various types of substances to the population. With this, I'm really talking about the alcohol industry and the way in which it actually has gone after and targeted various groups. Advertising is incredibly potent. We know that's true. We know it from the tobacco industry and the way in which they advertised. We know from their Virginia Slims campaign for women. We know that
I still know it. You've come a long way, baby.
Exactly, and we know exactly, and we know that in fact that was a highly effective campaign. So, actually, the beverage industry has been targeting women for quite a while. We have a lot of very powerful ads for women for all sorts of beers and wines and vodkas and other things, like book clubs, moms clubs, all sorts of things. So that's one thing that we know. We have, a vaping industry. We have flavored vapes. We have a lot of things that are appealing to kids and young people. We have now a cannabis industry that's taking a lot of its cues from the industries that have preceded it.
So what is the response from the public health community to these alarming increases in substance use disorder?
There are many, many responses, and many people have been working on this set of problems. I am a big believer in information. I think people need information about their own health. The Surgeon General just released a report in December about the risk of cancer posed by alcohol, and it was an excellent moment for him to release that report. What the Surgeon General was saying is that the evidence would show that there's no safe level of alcohol ingestion with respect to risk to cancer. Those amounts have been actually lowered because of the data that's come out. So for women, that's breast cancer, in addition to the other cancers like, throat and esophageal and stomach. Those cancers are all linked, to having a higher risk for those who use alcohol, any amounts really, and no amount has been shown to be safe. For women, breast cancer is one of these, and that's been known for quite a long time, but a lot of women still don't know that.
And where do women get this information?
So they get information from the media. That's one place they get it. They get it from social media. That's another place. I also think they can get it from healthcare providers. What you hope for is that people are going to be able to engage with a healthcare provider and just be able to tell them what's happening in their life. So it means having a trusting relationship with somebody in the healthcare community, but it also means that the healthcare community has to be armed with information that's up to date and be able to provide it to their patients, and that's across the board. Like the door opens in different places. The more doctors or nurses and other healthcare providers are able to give the information, it's another place. It's any place the healthcare system's touching you would be a good place to provide information. I don't think that necessarily is happening for all sorts of reasons.
When you were talking earlier about, when you have high blood pressure, your doctor says we're going to watch that. Well, a lot of people, but not all people, do have a yearly physical. I would say that nowhere near the number of people who are able to do that are able to have a yearly mental health check to check for any of these issues that you were talking about, depression, anxiety.
The thing we have not talked about, which I think is really important, is that in the United States, people do not have access to the mental health and addiction treatment that they need. And we haven't started to talk yet about treatment.
Let's go there.
We think about treatment sort of across the whole spectrum of treatment. Prevention is also treatment. But then we have, all types of intervention along the way. We do not have what we would call, quote, treatment on demand in the United States. It's very hard for people to find mental health care and addiction treatment across the boards. It's something I've had a lifelong career interest in fixing. We're nowhere near doing that. But I think it is really important for people to really understand how much treatment there is, and it's treatment that's been developed. We have 3 FDA-approved medications for alcohol use disorder. They are underutilized, but they exist, and they can be useful for people. We have 3 FDA-approved medications for opioid use disorder as well. And I have to say that we're talking about alcohol, we're talking about opioids, but nicotine is also a big killer, And there are many treatments for nicotine. And again, people don't necessarily take advantage of those. The other amazing news is how many, other types of therapies, behavioral treatments there are. And there are so many that have been demonstrated to be evidence-based and to help people. And they range across multiple different types of therapies, cognitive behavioral therapy, which can be incredibly useful for many people, sometimes with medications, sometimes without. There are different kinds of supportive treatments that can work for people. There are different types of group treatments. We at McLean developed with federal funding and clinical trials a group therapy for women with substance use disorders. And the reason for that was really to give women an opportunity to have a treatment that would take into account their very specific needs, and how addiction has affected them, both in terms of how they developed a substance use problem and also their recovery.
And this is the protocol that you developed?
Yes.
Yeah.
With colleagues at McLean, called the Women's Recovery Group. Cognitive behavioral therapies and other group therapies and other individual therapies has a manual so that any clinician could actually implement that in their practice And the point of developing that was that we know, and I mentioned this earlier, women are twice as likely to have depression, twice as likely to have anxiety, much more likely to have trauma or PTSD or an eating disorder. We know that for people to get better from having a substance use disorder, these other disorders have to be treated simultaneously. The data there is absolutely clear. That's 40 years of research shows.
You have to treat the person, not the disorder.
Exactly. The whole person. So, for example, the Women's Recovery Group also talks about other things that are very prominent in women's lives. Women, as you know, still are 90% of the caregiving force in the United States and globally. And what that means is that the roles that women have in our society include a lot of caregiving for children, for elders, for their community, a lot of people who depend on them. Those things actually really are important and figure in a major way for women, both in terms of their addiction and also their recovery. The other thing we haven't really talked about is that there are many, peer-led treatments that people use. There are many mutual help groups in the community, things that are, sometimes called self-help. We think of them as mutual help groups, things like Alcoholics Anonymous, Narcotics Anonymous, those things that are in the community, those are peer-led, and those can be very helpful for many people, sometimes on their own, sometimes adjunctive to other professionally led treatment. So there's a range of things that we know that really help people. There are many, many, many paths and many treatments available. You want to try to ensure that you're getting what's going to really help you, and that if you try something and that's not the right thing, there are other things. What is important is that, people may have differential access depending on where they live, who's near them. And the gap is, how do you get the treatments to the people and the people to the treatments?
So
Right.
my question is, what's the first step that you suggest somebody who wants treatment is ready to take that step? Where do they go? Who do they reach out to?
Yeah.
And before you answer, I just want to let our listeners know that we will include links to some of these resources on our site at radcliffe.harvard.edu/borncurious.
We have 3 agencies in the federal government. We have the National Institute on Alcohol Abuse and Alcoholism. We have the National Institute on Drug Abuse. And we have the Substance Abuse and Mental Health Services Administration. There is unbelievable amounts of information, including National Treatment Locator on the NIAAA site. That's for alcohol. There's also locators on the National Institute on Drug Abuse site. And there's more information on how to locate treatment on the SAMHSA site. That's the Substance Abuse and Mental Health Services Administration. And there's a ton of information, downloadable information for people to look at so they can educate themselves about what kinds of treatments are available. So that's part 1. Part 2 is, you want to find somebody to meet with that's, available and accessible to you, a provider in the community. You can start with many different kinds of providers. You can start in a primary care setting and talking to somebody. If you have a trusted clinician, somebody you want to speak to and talk to, that's a first place you can go. There are all sorts of people in the behavioral health sector, the mental health sector. You can find somebody in your community to meet with and talk to. If they're not the right person, hopefully they can actually refer you on.
But with the normalization of these behaviors, wine mommies and all of this, is it harder to get people to see that they might have a budding problem?
Perhaps. I think perhaps we were talking about peer groups and cohorts, and sometimes yes, but I think people are pretty good at thinking for themselves when they are provided information where they can compare and contrast and think about, is this really right for me? Is this really what I want? I think it is harder. It's definitely harder. And I think that's what I was alluding to in terms of you asking me about some of the uptick in the prevalence. We've been talking about the United States, but just so you understand, this is also true in Western Europe and Australia and New Zealand and many other countries.
What gives you hope about the future of treating substance use disorders?
Yeah, as I've said, substance use disorders are treatable conditions, just like other medical conditions. And it's really important to know that clinicians have been helping patients with substance use disorders for decades now, and we have many, many, and many more evidence-based treatments that have been demonstrated through research that they're effective and they're helpful for women and for men across the age span. We also know people recover. They get better. They're able to live healthy and productive lives. And as a health system, we know we also have a long way to go to ensure that people have access to the care they need and that we work to provide earlier identification, intervention, and treatment. But we can do these things, and we really can help people feel better and get better. We know because we've done it, and we've been doing it for decades. And what we just want to do is have the opportunity to expand that for more people and ensure that more people get what they need.
I am so appreciative of your work. It's so necessary, and I love that you're taking a really big, holistic view of it in order to get at the specifics of extending effective treatment for everybody, whatever their situation might be.
Absolutely. That's the most important.
Yeah.
That's the most important.
For everyone to feel better.
Yeah.
And stay better and feel well, really, through their lifespan. That's really the goal.
Thank you so much, Dr. Greenfield.
Well, thank you so much for the opportunity. I really enjoyed talking to you today. There's really so much to talk about. So I just appreciate the opportunity. And I hope that people will find it helpful and useful and be able to maybe talk about it with their family and friends.
Thank you so much.
And a final reminder to our listeners. Some of the resources you've heard about today can be found on our site at radcliffe.harvard.edu/borncurious.
Born Curious is brought to you by Harvard Radcliffe Institute. Our producer is Alan Grazioso. Anna Song and Cabin 3 Media provided editing and production support. Many thanks to Jane Huber for editorial support. And we are your co-hosts. I'm Evelise Estrada.
And I'm Heather Min.
Our website, where you can listen to all our episodes, is radcliffe.harvard.edu/borncurious.
If you have feedback, you can email us at info@radcliffe.harvard.edu.
You can follow Harvard Radcliffe Institute on Blue Sky, Facebook, Instagram, LinkedIn, and Threads. And as always, you can find Born Curious wherever you listen to podcasts. Thanks for learning with us.
And join us next time.